We have 2 viewers already. So I'm going to also open this up on another tab so I can make sure I get all the chat and details. I'm gonna kill this one. There we go. Ready? Oh, hey, I can hear myself. That's not allowed. All right, so gonna give myself an upvote because I'm good with that. And I just want to. Okay, so we have 1 watching now. Okay, so I will go ahead and kind of wait as some people roll in and send a couple more invites. Alrighty, so so I'll go ahead and get some dialogue going just for when we get people who come back and watch later. They don't have to wait 5 minutes into a video. But yeah, so just I guess go ahead and start filling me in on what you've been up to as of lately and what you're looking forward to.
All right. Well, since leaving Baylor College of Medicine, I've been doing a combination of clinical and non-clinical things. I've been doing consulting for hospitals and EMS systems to help them be more efficient with a variety of tox patients, but especially in venomations. I've been lecturing all over the country about snake bites and some other stuff. I work occasionally in the emergency department. I'm working on getting my snake bite service up and running, so we have a place in Houston for people to go for snake bites, especially when they get bitten by their exotic venomous snakes. And of course, I'm getting ready for the Houston Venom Conference. It's scheduled Saturday, May 16th. At the Westin Hotel in the Texas Medical Center. I'm expecting about 400 to 450 attendees. It's going to be bigger than we've ever had before. I'm also working on the New Orleans Conference, which is scheduled. It's the inaugural New Orleans Conference, and it's scheduled for November 7th. 2020. Still working on some of the details, but the Audubon Zoo will be involved. I'm very excited about that.
Ooh, Autobahn, like Germany Autobahn?
No, like the Audubon. Although I encourage people to drive fast to get there.
So actually, the last Houston Venom Conference, I was leaving the zoo after we had the meeting there, and I got rear-ended because somebody was driving too fast. So maybe people shouldn't drive too fast.
No, you should take a lift. You should take a lift.
Yeah.
Although we don't serve alcohol. Reception. That's the one thing I regret. That's the one thing I regret. We have amazing food, but no alcoholic beverages.
Is that just because of the venue, or?
Yeah, the venue liability. Plus, a lot of people who love snakes, get alcohol involved. They start playing with the snakes. And while that's good for business, it's bad for publicity.
That is a pretty good question. In your experience, what is how often is alcohol involved in snakebite?
Very rarely. We joke about it. We always joke about the risk factors for snake bites. And we're up to the 12 T's now. Testosterone, 20-something, tattoos, tobacco spitter, tequila, teasing the snake, Texan, all that jazz. But the reality is, alcohol is involved really infrequently. There was a paper out of UT Southwestern that showed that a small percent, less than 1% of bites were associated with alcohol consumption. And in my own experience, we know that most bites are the result of unintentional interaction, despite what a lot of old-time herpetologists will tell you. Most people are not intentionally messing with the snake before they get bitten. They reach into the bush, or they step on or near the snake and they get bitten. Alcohol is really uncommon, especially in the pediatric population. But even in adults, it's really not that common.
Okay. See, I've always wondered, and I know that it's a. Oh, there is a big echo. It's probably because I need to turn down my volume. Okay. Thanks, Ashley, for letting me know. But, and I'll turn my mic this way. But yeah, I know that, legitimate bites are more concurrent than, okay, yeah, it is because I hear you, and so people are hearing the echo. But I know that legitimate bites are more often, but I still tell people that messing with the snake tends to lead to more bites, just so people will stop messing with the snake.
Yeah, playing with the snake increases the risk of getting bitten, but that said, most bites still happen to people who are not intentionally messing with the snake.
Mm-hmm.
The exception to that, coral snakes. Of the 50 or so coral snake bites I've been involved with, I can only recall 2 that were not intentional. The rest were. Now, that said, sometimes they were people trying to do the right thing, like kids trying to save the snake from the middle of the road. They weren't bad, they were nonetheless messing with the snake. Or there was this one kid who was trying to liberate a coral snake that his older brother had captured and put in a cage, and he got bitten in the process of trying to save the snake.
Mm-hmm.
Felt bad for him, but he was messing with the snake.
I saw a video shared the other day. By the way, y'all let me know if the audio is fixed. I turned it way down on the speakers. If not, I'll just stick on those headphones. But I saw a video that was shared the other day. They tried reciting the rhyme, oh, red touch yellow, that means he's a friend of a fellow, or, they said it wrong.
Yeah.
But, and he ended up getting bit by a coral snake, but it was a dry bite. And it was some 6-year-old.
And there's 2 problems with the rhyme. First of all, half the time people can't get it correctly anyway. They're like red on yellow, that's a good fellow, or whatever, they can't remember.
Mm-hmm.
The other problem is that because there's so many, aberrant patterns, a lot of times people are like, oh, well, the red isn't touching yellow, that can't be a coral snake. And then they get bit by a black and yellow coral snake. So, of course, we know that in South America and Central America, there's so many species that don't follow that rule anyway. So the best thing is if you don't know what it is, don't mess with it.
Right. So, one of those things that you try to tell people, but they might not necessarily listen. So, hold on. I've got to go into my Skype settings real quick. We're going to take care of this audio issue. Control, comma. Audio and video. Speakers. Nope, we're switching to headset. Alright, okay, I think I hear you in my audio now. Or in my speakers. Or headphones. That's the word.
As long as you can hear me, as long as they can hear me.
Right, so now I look like an advanced bumblebee human sort of thing, but whatever
works. More operators are standing by.
Oh, yeah. Okay, so, but yeah, anyway, so I've got Jason and Ashley here, and then I've got 3 concurrent viewers, so I've got someone else here. Y'all are more than welcome at any time to ask questions. I imagine that third one's Hayden, just because she told me she was going to tune in. So, okay. So the 12 T's. Speaking of another T, though, tell me about your TV experience. How that's been for you.
Well, I mean, I was on a TV show 17 years ago. I'm not doing anything actively right now. I mean, I go on television now and then after, various toxicological emergencies. When there's something big in the news, like when our councilman died from an unintentional overdose a few years ago. But yeah, I don't have any regular gig. I had the opportunity to do a show, but I referred one of my younger childless colleagues because running around the world is not an old person's game or a middle-aged person's game. Not when he's got kids in school and work to do. Yeah, no, I mean, I'm not doing anything regularly scheduled. When toxicological stuff hits the fan, then I get involved.
Oh yeah. And I read that a lot of what your work ends up in is on the drug abuse side of things.
Fortunately, not as much anymore. I mean, clinically, for the longest time, intentional overdoses were the majority of what I treated. Mm-hmm. even when I had one of the busiest services in the country, snake bites and other envenomations only accounted for about 15%. I'm trying to raise that number by focusing more on envenomations and other stuff. But yeah, a lot of intentional overdoses. And then, with the pediatric population, the unintentional exploratory ingestions. We get the occupational stuff now and then, especially in Southeast Texas. But substance abuse, it's funny. That's kind of how I first made my name as a toxicologist. I did a lot of lecturing nationally on various, especially the novel drugs of abuse, but it's not my biggest interest. I definitely would rather take care of a snake bite or a Gila monster envenomation or a stingray envenomation than someone who's like high on PCP. PCP is fun to treat the first few times, but
Yeah.
But that's like the first day on the job. After that, it's okay. They're on PCP. It's calm them down and wait for them to chill out.
Right. And if you're having a slight off day and then somebody comes in on PCP, like for me, if I'm having a bad day at work, I can kind of just isolate myself, just like kind of grind till the 5 o'clock. But I don't think that's as possible in the medical side of things. Just because you have to be more at the top of your game at all times.
Yeah, and we figuratively and depending on which emergency part you work in, we literally work in a fishbowl. So we have to be there for them. That's the thing about emergency medicine. People come in with any complaint at any time, and we have to deal with it. If it's something really minor, we can deal with it quickly, but we have to be there for all things tox and non-tox.
Oh yeah, my last emergency room visit was for my dad. He went in. He had pulled his back, and he couldn't stand up and walk. And the person who came in right after us went before us because he shot himself in the leg. And we were just kind of over there sitting in the corner. It's like, okay, well, I guess we're waiting right now.
Yeah, no, I mean, the emergency department is one of the few places where being really bad off is an advantage because you get seen faster. But in the emergency department, we see everything. I mean, I've had people come in literally for paper cuts, and I've had people come in for these masses that were eating away at their tissue for 5 to 10 years, and people with massive heart attack, everything.
Mm-hmm.
And it's funny, you'll have people who will drive for hours to be seen in the emergency department for something minor, and then you'll have people who will drive for hours bypassing other hospitals to be seen by something that's life-threatening that probably should have been stabilized 2, 3, 4 hours before they arrived. So
I've seen that episode of House. It's because of lawsuits, right? He sues the other hospitals, so he doesn't go there anymore.
Oh, I've actually never watched House because I think as a toxicologist it would drive me crazy because allegedly there are so many toxicological exposures, and if they got anything wrong, I would be yelling at the television or the computer screen or whatever. So I think I'd better just avoid all of that by not watching it in the first place.
Yeah, there's some definitely questionable stuff. I'm a Hugh Laurie fan, but I think that's kind of the ignorance is bliss side of things, which. Yeah, that and I'm sure any other medical show, but
yeah, I mean Scrubs was inaccurate, but it was also entertaining, and it wasn't intended to be accurate, so that's okay.
Right.
Now, it's interesting. Like I said, I've never seen House, but for a long time I felt connected to him because before I had my back surgery, I had a limp, and I was good at diagnosing things, and I had a low tolerance for people, so. He was like my spirit animal. But although I never popped pills, and it's my understanding he was addicted to Lortab or something.
Yeah, it got to hold on. Current bit rate is lower than recommended bit rate. Okay. Sorry, adjusting more settings.
That's
as
okay.
Always.
Yeah, I think anyone who knows us. Who knows me knows that my addiction is kolaches, not narcotics.
I still have that video of you at the last Venom conference eating kolaches. I'm going to set it to some pretty sensual music and
In my defense, I have not had a kolache all day.
Oh, yeah.
And I've only had 2 in the last 48 hours.
Well, that reminds me of my friends in high school that would smoke weed. They would say, hey, I haven't smoked in 2 weeks. And I would just tell them, so you've been broke and or busy for 2 weeks? But anyway, somebody also said House MD rule number 1, it's never lupus. That show has a reputation for constantly um, constantly saying it's lupus, and then somebody asks you how you feel about Grey's Anatomy.
I've never watched the show, and I'm not aware of anyone named Gray, so I can't comment on his or her anatomy.
Right.
No, I've never actually seen that show.
But yeah, neither have I. I hear it's like Game of Thrones of the medical world, and everyone dies. But back onto the subject of toxicology. So from what I read, you got your start in Arizona while in the Air Force.
No, I went to Arizona after I got out of the Air Force.
Okay.
So my background was EMS, and I knew when I entered medical school I was going to go into emergency medicine. And for all but 6 hours of medical school, I knew emergency medicine, and I liked everything about emergency medicine. I had taken a toxicology elective in graduate school before medical school, so I was aware of it, but it wasn't like it stood out among other things within emergency medicine. So I liked emergency medicine. That was it. And I went to Vanderbilt for my residency, and I was more interested in EMS than anybody else was. But shortly after I started my residency in Nashville, I met Donna Seeger, who was our toxicologist and who at the time was president of the American Academy of Clinical Toxicology. And I realized I loved what she did, and I had a passion for toxicology, and I had an aptitude for toxicology. So I finished my residency, and I went on to active duty to pay back my military obligation. So I started teaching toxicology for the residency program affiliated with the Air Force. And I liked everything about tox. I liked the overdoses, I liked the occupational stuff, I liked the plants, the mushrooms, the envenomations, everything. It wasn't until I was in Iraq with very little to do, because I only had like 10 patients in 140 days, when I started studying the local fauna, and I became kind of fascinated, because we found a snake on the property, and there were scorpions and some other things. I'm like, this is really cool. And at the same time, it was really hot there, like 135 degrees, and I realized I love that weather. So I'm like, where can I go that's hot and I can learn all about envenomations? So I did my fellowship at Banner Good Samaritan in Phoenix, which historically treats the most or among the most bites every year. So that's when I got my formal toxicology training, and that solidified my love of snake bites and other envenomations. And I stayed in Arizona for a while, and then I moved to Texas 8 years ago.
Okay, so and if I'm correct, Arizona also has the most diverse amount of crotalids. So, or
I don't know about that. There's about a dozen species. I think Texas may have more because Texas is so big. Not to mention Texas has all the echistrodons. But I'll tell you, where I practice, I only see 5 species of native snakes. Where I am, I see copperheads, I see coral snakes. So I guess I see 6. So I see 5 pit vipers and coral snakes. So I have my Texas coral snakes, I have my copperheads, my cottonmouths. I see western diamondbacks, I see timber rattlesnakes. And actually, I guess I've never seen a pygmy rattlesnake bite here, but they're apparently out here. But in Arizona, I did see more variety. Not to mention, a lot of our patients were transferred to us from elsewhere in the state or even other states. So we saw a lot of western diamondbacks. We saw Mojaves. We saw speckleds. I saw a lot of speckleds in Tucson. We saw rock rattlesnakes. We saw sidewinders. Occasionally a ridge nose. So I saw more variety there. But I think Texas, the state, has more species overall.
okay,
But
yeah,
that's not an official statement. I'm not testifying to that
right.
unless I look first.
Yeah, it's. I just think as far as let's see, total rattlesnake species, I think Arizona would have more, but we also have the copperhead, cottonmouth, different ones like that. So yeah, and that would make sense. So, trying to think of other things. What about other than? Did you ever treat anything outside of snake bite? I guess scorpion.
Oh yeah, so we had hundreds of scorpion stings. It was funny because I was teaching toxicology in Ohio without before I even did my fellowship. I just had a few months of extra training residency and then a few years of learning on my own. But we didn't have scorpions in Ohio. So when I moved to Arizona, my first night on call, I had 5 consults, and 2 of them were Arizona bark scorpion envenomations. And we were actually doing the study for Anascorp before it became FDA approved. And it was amazing how significant those stings were. I mean, we'd have these kids getting massive doses of pain relievers with no relief. 500 micrograms of fentanyl in an hour.
Oh my
And then
gosh.
gave them the antivenom, and they were better within 30 minutes. It was phenomenal.
Right.
It was really amazing. So we saw a lot of those. We saw some spider bites. We saw Gila monster bites. In fact, the worst envenomation I have ever treated wasn't a snake bite. It was a Gila monster bite. A guy decided to be a desert pirate. He put a Gila monster on his shoulder, got bit on the neck. Next thing you know, he was practically dead. So that was pretty cool. Yeah, he spent an entire week on the ventilator. I never got a chance to hear him speak because I had to sign off to one of my partners after a week, and then he got extubated. But yeah, it was funny. He came in right after a snake bite, and the snake bite, the victim, she was stable. So I said something to her that I've said to no other snake bite victim before or since. I said, "Excuse me, while I go see somebody more interesting." And she knew because this guy was so sick. It was and of course, one of the things you see with a really bad Gila monster envenomation is massive diarrhea. And for better or for worse, he had that massive diarrhea. I just got to say, our nurses earned their paychecks that night.
Oh yeah.
So.
And with Gila monsters, you have to pry them off. So I imagine he was bleeding a lot too.
No, I mean, he didn't come to our hospital immediately. He was transferred. So, but it was my understanding the Gila monster got off pretty fast. Mm-hmm. So I think that's one of those myths, along with like coral snakes having to chew. Sometimes they latched on really hard, but not always.
Right.
And there are some tricks to get them off. But by the time he arrived at us, he was Gila monster free. He was just critically ill. Right.
So, Hayden, also, if you're in the chat, give us your 2 cents on Gila monster bites.
She talks about how bad her Gila monster bite was, but hers was nothing compared to some of this, which is good. I mean, I'm glad she didn't, lose a limb or have a life-threatening illness. But yeah, we didn't see a lot. I saw maybe 12 or 13 in my time in Arizona, but some of them were bad, and this one, of course, was the absolute worst.
Right. Sorry, I took a bite.
That's okay. I'm just mad that I've got no food here.
Right. Oh, well, yeah, before this, I was out filming for a martial arts school, and so doing a Facebook stuff for them. But I wanted to make sure I was back here, set all my lights back up. But yeah, no, with Gilas, they're so slow moving, but it's when you hold them, I think most bites were around the hand for Gilas.
Except for this guy who got bit in the neck, yes.
Yeah, so, really with them, did they also face, like, legal trouble because they're most likely messing with the Gila monster?
I don't recall that ever being the case. One was a grad student who got bit, who was collecting Gila monsters and just got bit through a sack, actually. She had a Gila monster in a burlap sack next to her, and it bit her through the sack. A few people were just messing with them, but didn't... Yeah. I'm not aware of any legal action because they're not protected, to my knowledge, or I don't think they were protected back then. Remember, I left Arizona 8 years ago.
Right.
So I don't remember anyone having any legal stuff.
And then I guess my last question as far as Arizona for now goes, what about people crossing over? Because I know there's El Camino al Diablo, like that goes from Yuma across the southern... and then it goes kind of across the southern part of Arizona. Did you get immigrants trying to cross over and they got snake bit, different things like that, or?
Yeah, we would definitely get some, more so in Tucson than Phoenix, but we definitely got a few people who got bit while trying to cross. But I mean, I also see that in Texas on occasion.
Right. So, I guess on to snake myths. What's your favorite snake myth? The one that you just, you always have a clap back for, and you're...
Favorite myth. Would this be like the one that's so egregiously wrong, or that I hear the most? There's so many myths. There's myths about the snakes themselves. The myth that juveniles are more dangerous than adults, or the myths that coral snakes have to chew. Obviously, there's myths about the severity or lack of severity when it comes to bites. There's some people who will tell you that you get bit with a rattlesnake, by a rattlesnake, you're going to die unless you get rushed to the hospital immediately. And fortunately, that's generally not the case. On occasion, yes. Conversely, there are people who tell you that copperheads don't need to be treated. And we know that most copperhead envenomations should be treated with antivenom. My co-authors and I, we published all the studies showing that even the mild bites recover faster and have fewer opioid requirements when they get treated. Those are myths. You'll hear some people say that no one's ever died from a copperhead bite, and that's complete baloney. There's a death last year from 2012 to 2019. There were 3 deaths reported from copperheads, as opposed to 0 from cottonmouths. some people tell you that coral snakes, are the most dangerous snakes. But the reality is, I can only name 5 deaths from coral snakes since 1950 in the United States. Now, Central and South America, there have been some others, but although not many. But I can only name 5, and I heard a rumor of a 6th one, but I haven't seen any documentation of it. And when it comes to Texas, the only death I'm aware of from a Texas coral snake occurred in 1970 in a 7-year-old boy in Burnett County. They're painful. And in fact, that's kind of the focus of my research right now. It seems like the bites in South and East Texas are different from the bites in North and Central Texas. But the ones in South and East Texas, the ones that I'm treating, they're horribly painful, but they don't do anything beyond that. They don't cause any objective neurotoxicity. They don't cause weakness. They certainly don't result in respiratory paralysis. But that's what I'm studying right now.
Right. I remember you had your Tale of Two Coral Snakes last year. For the Venom conference, are we expecting an update on that? Or are you going to have other topics you want to touch on this year?
So we're not specifically addressing coral snakes this year. We do have a bunch of snake lectures. Eric Lavonis, our keynote speaker, who's been the principal author or senior author for a plurality, if not a majority, of snakebite articles in the last 20 years. He's our keynote speaker, and he's going to talk about all sorts of, relatively new information, stuff that people may not know yet. Of course, we'll talk about both the pre-hospital management and in-hospital management of snake bites. And I'll touch on coral snakes briefly, but I only have 30 minutes to talk about all the in-hospital stuff. And then we have Kristen Wiley from the Kentucky Reptile Zoo talking about how they use venom and how venom can be used therapeutically and other commercial uses of that. Other than that, I can't recall any other specific snake lectures. We have a lecture on scorpions. We have a lecture on medically significant spiders in the U.S. But I'm sure questions will come up when we have the Ask the Experts panel. People always want to know about various snake things.
Right. And for those of you who don't know who Kristen Wiley is, her husband is Jim Harrison, who, if you get bored, you can go on to Facebook and watch him just grab king cobras and milk them. He milks some pretty venomous stuff. It's dedication, and it's all a nonprofit. So I'm excited about her being there because I was supposed to swing by Kentucky on my way to Indiana last year. Didn't get the chance. Do you know if Jim is coming down as well, or is it just her?
I don't know. I know they're both going to be in Gainesville for Venom Week in March, but I don't know if they're both coming down for my conference.
Right.
Hopefully. I saw them back in September when I went up there to visit.
So yeah, you had talks. I think I had seen you at Conroe right before, and you had like a little mini tour.
Yeah. I gave 8 lectures in September. It was fun, but it was a long trip, a long series of trips. And then I couldn't even come home because it was flooding in Houston. So I had to just go hang out in northern Kentucky and Cincinnati and eat some good food from a brewery. It wasn't the worst thing ever, but.
So what's the most interesting thing on your rider? Some people have green M&Ms in a bowl. Other people have, their own things.
Depends on who's footing the bill.
Well, I've got green M&Ms, the jalapeno chocolate ones I need to send you.
I do want to try those. I've given up most candy except for dark chocolate, but I'll eat jalapeno anything. I definitely need to try that.
Mm-hmm. So, did you have any main mentors growing up? I know a lot has developed over your career because, now we have Anavip, and then we had Crowfab, and then before that, started
the YFACP.
Yeah.
I was around for the tail end of that, and I saw some bad reactions to that. I'm glad it's gone.
Oh yeah. So, no one still treats with Wyeth in the U.S., I imagine.
No, it doesn't even exist.
Okay, so, do you think there's going to be, as far as development, do you think there's going to be enough advancements where, it's like an EpiPen for Venom? Is that, what's the possibilities with anti-Venom?
Yeah, that's a great question. I don't know if I'm really qualified to answer it. People are looking at alternative to anti-venom. People are looking at medications and non-pharmacological interventions that could either serve as an alternative or at least a bridge to anti-venom. Certainly, for neurotoxic snakes, there are some potential interventions that wouldn't be applicable for the hemorrhagic ones or the ones that cause tissue damage. It's interesting, I don't know. We'll see.
Right. The Narcan for anti-venom,
Do what now?
Oh, the Narcan for
yes.
snake bite. So, but
yeah, we'll see.
But yeah, did you have any sort of mentors that were around? People that you always say, hey, if I don't know something, let's go.
Oh, absolutely, absolutely. I was blessed. I had some great professors in college. Now, obviously, they're not medical, but I had some, phenomenal instructors in college and in graduate school and in medical school. But really, it was starting residency. The person I always give the most credit to is Donna Seeger, our toxicologist. If it weren't for everything she did, I probably wouldn't have fallen in love with toxicology, and I'd have a completely different career path. But my chairman, Corey Slovis, who's a famous emergency physician, and our program director, Keith Wren, his professional partner for 20 plus years, they were both amazing inspirations. My first attending job when I was in Ohio, I had some great mentors, even though, because I was junior faculty. So we had, the leadership at Wright State University, Doctors Hamilton and Singer and Brown and Whiteman. And of course, in the fellowship, that's really what did. Michelle Rua, Steve Curry, Dan Brooks, Frank Lavecchio, Erin O'Connor. These are people who have been there and done that in toxicology and specifically in envenomations. I was lucky enough to have some great mentors / colleagues when I was at University of Arizona, Frank Walter and Mazda Shirazi. It was a little weird going to Houston where I was like the man. I had nobody above me for toxicology. I was the only toxicologist in the entire city. But I could always contact these people with questions. And of course, now I have some, colleagues around the country that I work with, that I lecture with, that I can bounce things off of. Like I said, Dr. Lavonis, who's our keynote speaker. I have the pleasure to often work with Dr. Bill Banner from Oklahoma and Dr. Tom Arnold from Shreveport and Rick Dart from Denver. I'm lucky to be in this small enough community where I know like the people who've been there and done that, who've published literally hundreds of articles, and I can reach out to them when I have questions.
Mm-hmm. So, because I know you always get tagged in all the posts, and I'm sure that takes up so much of your time. And I'm sure you have a copy paste thing where, just right click.
I have about 8 smart phrases in my phone to answer most common snake questions.
And then, so when toxicologists get together, when it's a round table and y'all are at a bar having some drinks, what are y'all's topics of discussions? What's the debates there?
Well, just because we're all toxicologists with an interest in venomations, that's not all we talk about, obviously.
Oh, right.
There's some political discussions, but obviously, the controversy is about when to pull the trigger on antivenom. Mm-hmm. Which antivenom to use, what kind of testing is necessary, what kind of setting do they need to be admitted to. When I was working full time in Houston, of the roughly 400 snake bites I treated, I only admitted 1 patient to the ICU the entire time, the intensive care units. Whereas many hospitals, a snake bite automatically goes to the ICU. And I really question the wisdom of that because, you have limited intensive care unit beds. It's obviously a lot more expensive, and it may not be what the patient needs. Now, ironically, there are some hospitals where the floor nurses and the hospitals who treat patients on the floor are actually more familiar with snake bites than the nurses and the physicians in the ICU. So they may get actually better care. So, we talk about that. We talk about our favorite snakes, when we were envenomated or when we're going to be envenomated. Like, I have not been envenomated by a snake yet, but I think most people agree it's going to happen at some point. I've almost been envenomated twice. And admittedly, the day's not over, so, we'll see what happens. But, yeah, we talk about all sorts of things. We talk about who's the best, radio interviewer, who's the best YouTube interviewer. So far, you're on the top of the list of the YouTube interviewers, in an N of 1. But
right. Up until Port City Pythons tries to come and swoop you up.
Well, they haven't reached out to me directly, so.
Right. He should be. I wonder if he's watching.
I saw I think a T-shirt that said something about that, but.
Yeah, he used to live here in Texas, but but I'm gonna send him a message. Come jump on the stream. Oops, spelled stream wrong. And then I'm gonna say Dr. Greene is talking smack about you. So, but that's how I invite people to things. I just tell them, hey,
rile them up.
Yeah, come here, fight me. But uh, let's see. I had a tangent I was gonna go off on, but I had another tangent come to mind. But so, as far as spreading proper knowledge, because I know there's still hospitals around that, the first thing they want to do is a fasciotomy, how do y'all go about spreading knowledge to medical centers that don't have toxicologists full time?
So that's a great question. It's tough. So here's the thing. Most physicians don't receive any formal training in snake bites. Mm-hmm. It's part of the emergency medicine curriculum, but the quality of that's going to vary greatly depending on who's doing the teaching. You don't have to be a toxicologist to be a snakebite expert. I mean, look at Sean Bush. He is phenomenal, but he's not a toxicologist. He's an envenomation expert. Mm-hmm. Conversely, there are many toxicologists who don't know very much about snake bites because they literally never see them in their careers. I had the opportunity to do my training in the Northeast, and I chose not to go there because it was not really in alignment with what I wanted to do. But I have friends from there, and one of them once mentioned to me, and she's been doing this even longer than I have, and she's like, I've treated one bite in my career. So there aren't that many people who really know what to do. And just misinformation gets passed on from physician to physician, generation to generation of doctors, and sometimes they get really good at making bad medical decisions and bad treatments for snake bites. And a lot of hospitals, they don't recognize that they don't know what they're doing. And then, I hate to say this, but a lot of the for-profit hospitals don't care because it's cheaper to not treat, and a lot of them figure, you know what, the patient will probably be fine. And so here's the thing. Even untreated, many bites will do okay. The problem is, not all of them will. One of the reasons I'm so aggressive with my treatment is because there is an unacceptably high, or what I think is an unacceptably high, incidence of permanent disability or disfigurement in patients who go untreated or who go undertreated. Mm-hmm. In Texas, I think, and I hate to say this, but it's true, a lot of doctors get away with not treating as well as they should because it's so hard to successfully sue a doctor that they're taking their chances. And again, most people are going to do fine anyway. But I have scores of examples where bites were untreated or undertreated and the patient ended up with permanent problems. There's some cases I'm involved with as an expert, as a legal, advisor, as an expert witness. And there are other cases that I've managed clinically after other hospitals didn't treat them. One of the things we're going to have at this year's Houston Venom conference, we're going to have the patient and parent panel. Patients or their parents are going to talk about their experiences. And some got treated correctly immediately. Others got treated correctly after they went elsewhere. And some just never got treated correctly. And you'll hear about some things that other hospitals do. So my job, or I feel like my job, is to educate as many people as possible. That's why we've been doing the Houston Venom Conference for years. This is the 8th year we're doing it. That's why I try to do as many lectures, get invited to do grand rounds, or, collaborate with the pharmaceutical industry to get into hospitals to give lectures. The problem is some hospitals, especially if it's a drug company sponsored talk, they don't want to do it because they feel like it's be too biased. So there are many hospitals where I know they're not managing bites correctly, but they don't want an outside speaker to come in.
Right.
So it's frustrating. We use National Snakebite Support on Facebook to disseminate as much information as we can. And I think we've made some great strides, and I think we've helped dozens, if not hundreds of people directly, and hopefully we've helped hundreds, if not thousands of people indirectly. But there are so many more people and so many other medical facilities that just don't have the experience. Sometimes I feel like we're fighting an uphill battle, but every once in a while we really help someone, and it's really gratifying.
Right. It's a culture change, and so it's, can't do everything, but do what you can.
Right. And, I know that people have been helped both directly and indirectly over time. So that's good.
Right. And I read up on a squam bite that happened to someone that you consulted on, and how they had to get PT for however long, and I it's kind
Yeah.
of like I'm a glutton for punishment in the fact that if I get into a certain snake, I want to know the worst things that can happen. I want to know possibilities, because I was photographing the squams this weekend, and I laughed. I was like, hey, I'll be fine if anything happens because Dr. Greene's here. Um, just interrupt him from his talks, and just, oh, hey, let's go get some. Let's see. Squams don't have an anti-venom. They just have a
So no,
similar one.
there's no actual antivenom for squams. Now, I don't want to violate HIPAA, but I know that that story about the squam bite was posted in a lot of different forums.
Hmm.
We actually used two different antivenoms for that case, and we started wondering afterward, which one was actually the better one. So we were able to get the snake. The actual snake was donated to us, and we sent it down to Kingsville, and we did a small Venomic study in a mouse model. And in this very limited study, we actually found that the South African polyvalent was more effective than the Ecus antivenom. Clinically, I'm not sure which one made more of a difference. I gave the polyvalent first; it didn't really have an effect. Then I gave the Ecus. Then she got a little bit better, but it could have just been timing too.
Hmm.
So I think that warrants a bigger study, funded by someone who has more money than I do. But yeah, there is no approved antivenom for squams. Now, I've treated a few squams. That was obviously the worst. Others, fortunately, had very minimal tissue injury and no systemic toxicity.
Okay, so in other words, you are giving me permission to bring one into my house. Um, Permission just for my
You,
girlfriend.
you have permission to bring in anything you want. Just realize we may not have the resource to take care of you. So there's a famous, or really more notorious, person in the snake community, in the herp community.
Oh,
Um, Yeah, you can probably. I'm not going to name any names. I treated this person after he got envenomated by one of his captives, and he did a lot of publicity about his bite, and people saw how he sustained the bite. He had a number of species at home, and the one that bit him, fortunately, was one for which I had the antivenom readily available.
hmm.
He had some exotics for which I also had the antivenom, but he also had an exotic for which we don't have antivenom in Houston at all. And that would have been a little more challenging to treat. Now, fortunately, that was a primarily neurotoxic snake, and ultimately we can treat neurotoxic snakes without antivenom because the thing you worry about is respiratory failure, and we can put those people on a ventilator. But had he been bitten by this Australian neurotoxic snake, he probably would have ended up on a breathing machine.
Oh yeah, and kind of like the blue-ringed octopus, you just got to get on a ventilator. So
But yeah, the problem is with the blue ring, people don't realize they've been envenomated and they keel over and die.
right,
And ventilators don't fix dead;
but
they
yeah,
just
so
prolong breathing.
somebody's naming someone in chat, but you did not name anyone. Also, somebody says needs to
Yeah,
be
far
easy.
be it from me to mention anyone's name on social
Oh,
media.
he's notorious, so it's kind of like, um, me saying I'm not gonna name any names, but this person was a influence among, I don't know why it's not focusing, among many people, but you know, uh, but yeah, no, free handling. Kristen Wiley actually just shared a video the other day of somebody in, I guess, India, and they were holding this cobra, and it struck him in the arm, and then he like pulled it off and he bopped it on the head, and then it struck him in the face, and you know, it's like stop, please. But so what are the let's address the most common questions you get on uh, on these forums. So things that you almost want to say, hey, go read, uh, go read the rules, and then or
Okay.
go read this page.
Okay. So the most common questions I get, am I single? Okay, so no, I'm not. No, but snake-wise, people always ask about the extraction device. These things are sold in Dick's and Academy and Cabela's and outdoor. Extraction devices do not do anything helpful. They make money for the companies that sell them or produce them, but they do not remove venom. They are useless. The best editorial ever, or at least the best titled editorial ever, came out in February 2004 in the Annals of Emergency Medicine. Extraction devices do not remove venom, they just suck. Similarly, pressure immobilization is great for exclusively neurotoxic snakes so long as you do it correctly. When tissue damage is likely, we don't recommend pressure immobilization. Benadryl. For a year, people were saying, oh, Benadryl is the panacea for snake bites.
Oh, yeah.
Because histamine isn't playing a major role in snake envenomation, antihistamines don't really help. Are they harmful? In and of itself, no, Benadryl is not harmful. But if you think that it's an alternative to getting appropriate care in a hospital, getting the definitive treatment, which is antivenom, then it's harmful. If it delays care, it's bad. Benadryl will not help. I don't care if you're a cat or a dog or a human. Benadryl does not help for snake bites unless you're having an allergic reaction. And even then, a life-threatening allergic reaction doesn't need Benadryl, it needs epinephrine. We get asked about who gets bitten. As I said, most bites are the result of being unlucky, unintentional interaction. We get asked about antivenom. Like I said, most pit viper envenomations should be treated. Even the mild bites get better faster, and they have fewer opioid requirements. And I'm not aware of anyone who was treated in a timely fashion with antivenom who had permanent disability disfigurements, whereas I know a lot of patients who went untreated or undertreated who do have permanent disability. So I think most pit viper envenomations should receive antivenom. And then you mentioned surgery. Surgery is almost never necessary for a snake bite. Now, there are some states where surgeons never touch snake bites. But Texas has a rich history of surgeons being involved with bites. And there's a few reasons for that. The first case I heard about when I moved to Texas was a woman who came in with a cottonmouth bite. It was a moderate to severe cottonmouth envenomation. And at the hospital, I'm not naming it, but it's in Richmond, Texas, she got antibiotics and she got steroids, two things you don't need for snake bites. She didn't get antivenom. She got worse, not surprisingly. So they cut off parts, they did a fasciotomy, and she ended up having a lot of tissue loss and a permanent disability, permanent neurological deficits. People for years thought that you should prophylactically do surgery. And then, the more hip ones were like, okay, well, we only do it for compartment syndrome. But here's what you need to know about surgery and snake bites, okay? A legitimate compartment syndrome following snake bite is exceptionally rare. I've treated about 800 bites. I've never seen an actual compartment syndrome. I've seen people suspect it, but if you measure the pressures, if you examine the patient, they don't have a compartment syndrome. But here's what's even more important. Compartment syndrome from snake bite is pathophysiologically different from compartment syndrome from a crush injury. Treating the elevated pressures in a snake bite is accomplished by treating the underlying problem, which is the venom effects. You give antivenom, and that solves the problem. Surgery is only indicated for a legitimate compartment syndrome that fails to respond to antivenom. And knowing how rare a true compartment syndrome is, and knowing how rare it is for antivenom to not work, you pretty much do not need a fasciotomy for snake bite. And when people, especially at these smaller community hospitals, start getting a surgeon or an orthopedic surgeon involved with a snake bite early, it's premature and it's potentially dangerous. As for delayed surgery, every once in a while, someone will have full thickness necrosis, and that necrosis has to be removed. The finger gets cut off or whatever. Mm-hmm. But all too often, I see people get surgical intervention for something that's less than full thickness. I have a whole series of pictures of fingers that look terrible, and someone wanted to operate. I said, no, just treat them conservatively, and every one of those recovered fully. Surgery is almost never necessary, and I don't think a surgeon should be involved unless a snakebite expert, and there are so few of us, unless the snakebite expert has specifically said get a surgeon involved. I don't think they should be even seeing the patient, because once they get involved, they may want to intervene, and that's not in the patient's best interest.
Right. See, I've had these rural nurses ask me, they say, oh, well, I've got people who are out hunting, and then they're out there for 30 minutes and they have to walk, which increases their heart rate. And then they go to the hospital, and, they tell me all these things on what if, what if, what if, what if, what if? So,
Okay, you brought up another thing too. Positioning. This is a real big thing. How do you position the affected extremity following a bite? So we'll talk about two phases, pre-hospital and in-hospital. There's no question for pit vipers, once they're in the hospital, we should elevate as high as possible for as long as possible. It reduces the swelling, it reduces the hydrostatic pressures, they recover faster. You can see dramatic improvement within like an hour when you start elevating. There's no question. Now, pre-hospitally, it's a little bit controversial. Some people argue that you shouldn't elevate because it will, quote, enhance the absorption of the venom. Realize the volume of venom is so insignificant that I can't imagine elevation will make any difference. It's not going to have any effect, but it will reduce the amount of swelling. If you're reluctant to elevate pre-hospitally, keep it at or maybe a little bit above heart level. What we don't ever want to do is keep it below heart level because that will absolutely increase the swelling, which leads to increased tissue injury because of the hydrostatic pressures, etc. So I'm an early elevation advocate. I think the second you get bitten by a pit viper, pre-hospital or not, elevate. They'll feel better, and it's not going to make that much of a difference in terms of systemic absorption. And certainly, once they're in the hospital, we elevate. It helps them tremendously with the local damage. And even if it were to increase systemic absorption, which again, I think is negligible, but even if it were, so what? You kind of want it to because that's how the antivenom can interact with the venom. So in theory, you're facilitating that. But yeah, positioning is important. I elevate as high as possible for as long as possible, and I've had great results. And we're talking hundreds of patients, not one or two. Elevation makes a big difference.
right. See,
And of course, we don't do tourniquets.
right, yeah, right. And then I remember you guys addressing tourniquets at the Venom conference last year, saying if somebody has it on, keep it on until you get to the hospital.
Yeah, and then you want to get the antivenom going and slowly take it on. I mean, it depends on how long it's been on. If it's been on for 1 minute, that's different from an hour.
Right. So,
but yeah, don't apply it in the first place. That's even better.
And then I've got Jason Waitley, 3211, asking, do you ever treat prophylactically for rhabdo in cases of serious viper envenomations?
Do I ever treat prophylactically for rhabdo?
Yes.
Well, the treatment for rhabdomyolysis is by giving lots of fluids. Mm-hmm. So I think you need to walk a fine line. You want to maintain euvolemia. You want to make sure they have appropriate volume. What you don't want to do is give too much volume because one thing you see with pit viper envenomation is third spacing. If you were to give a lot of fluid, all that fluid is going to leak out of the blood vessels into the affected extremity. That can make the swelling worse. So we monitor for rhabdo and we give fluid appropriately, but we don't go nuts. Well, we shouldn't. Some people probably do, but they shouldn't because you can actually aggravate the local damage. And fortunately, rhabdo's not that common. I check CKs on a lot of my snakebite patients, and they're generally not elevated.
Right. So on oh yes, somebody's making fun of Jason, saying he's being all fancy. On a lot of reports, and then a lot of rural conversations that I have with people, they talk about how much antivenom a hospital has given. So it's like, oh, they give them 30 vials, they give them, right. 60. So as far as, with you being somebody who treats pretty liberally, how do you, what's your, I guess, of course it all depends on weight and different things like that, right. But what are you looking to okay. As far as, what's kind of the peak of the most you've had to give someone?
Okay. So let me address the number of vials. You brought up an interesting point. I'm liberal in that I treat a lot of patients, but I don't treat them with a lot of antivenom. Mm-hmm. So in my experience, there's two reasons why people get a large volume of it, or a large number of vials of antivenom, because they're critically ill or because they have someone inexperienced managing the bite. Okay? Mm-hmm. The average patient gets about 14 vials. For a copperhead, it's about 10 vials. And I would say I treat about 85% of my pit viper bites with antivenom with an average of about 12 vials. So I'm not giving a lot. I'm just giving a lot of people antivenom. I've had people systemically ill. There was a guy when I was a first-year fellow who had gotten 28 vials in the first few hours because he was so sick. He was hypotensive. He had airway swelling. And he ended up getting 40-something probably, or 30-something. I think the most I've ever given is something in the 40s. I'm aware of someone who got 96 vials. Although I suspect part of that was because there was a really not conservative, but a really fearful attending physician who just, there are times when, you've given enough antivenom and there's just some lab abnormality you can't correct. There's no point in giving additional antivenom at that point. If someone got 30 vials, maybe they were critically ill, or maybe they just had someone who didn't know what he or she was doing.
Right.
So the most I've given is 40. The average is about 12. That's all I can say.
Right.
And of course, the sooner you give it, the better. The analogy I like to use when it comes to snake bites is a fire. If you have a tiny little contained fire and you take a little bit of water, you can extinguish it. Historically, a lot of physicians, especially in Texas, well, primarily in Texas, have taken a wait-and-see approach. They want to see how bad things get. So they let this fire, if you will, spread. And then once the damage spreads a lot, then they decide to extinguish it. At this point, you need a lot more water. You need a lot more resources to extinguish it. And you've ended up causing more damage. So some people get more antivenom because they waited too long to pull the trigger. By extinguishing it early, by getting initial control quickly, I end up using fewer vials. So maybe more patients are getting it, but they're getting less because we've controlled things quickly.
Right. And I know I've seen the posts on the page where, like people tell you, oh yeah, they sent me home, they didn't give me any antivenom. And you're like, I can just imagine you rubbing your temples saying, go back, just go back. And
yeah, it's frustrating. People go untreated way too often. Mm-hmm. I don't know if it's laziness or ignorance or fear. Some people are afraid to give antivenom because I remember 30 years ago, my uncle's brother's best friend, whatever, drinking buddy had a bad reaction. But again, the stuff we use then is very different from what we use now.
Right.
Depending on the study, the incidence of acute adverse reactions to Crofab is anywhere from 1.4 to 8%. And there was a big meta-analysis published in 2012 where there was an 8% incidence of acute adverse reactions. Using data from the North American Snakebite Registry is about 2.3%. And the big study out of Arizona from the Poison Center with over 1,000 patients, the incidence of acute adverse reactions was 1.4%. That's like the acute adverse reaction incidence to tap water.
And I hear it's lower in a lot of instances with Anavib.
Actually, I've heard the opposite, but the thing is, we don't know for a fact.
Right.
Yeah,
it's still kind of early to.
Both Anavib and Crofab lack the FC portion of the antibody, which is primarily responsible for the immunogenicity.
Mm-hmm.
So they're both going to have much lower adverse reaction rates than Crofab, than YF-ACP. We have those three studies on Crofab that I mentioned, 1.4, 2.3, and 8%. To my knowledge, there's no study that specifically looks at the safety of Anavib. Anecdotally, I've heard some people having reactions to it. And of course, people have reactions to Crofab too. There's a case report I published of a woman who had a severe reaction because she had a latex allergy. But in general, it's a really low incidence for Crofab. It's probably low, but we don't know the answer for Anavib because it hasn't been published yet.
Mm-hmm.
But one thing that's really important to remember, there's no absolute contraindication to antivenom if you need it. If you have a severe envenomation, even if you're worried about an allergy, we can treat an allergic reaction. We can treat an anaphylactic reaction. We can give them epinephrine. We can intubate them. Antivenom accomplishes something that nothing else can do. You can't help the tissue damage with surgery. You can't help the thrombocytopenia by giving platelets. You have to give antivenom. Even if they're having an allergic reaction, you treat the allergic reaction simultaneously. You don't withhold the definitive treatment. Mm-hmm. And there have been cases of people having severe reactions who didn't get it because of an allergy, or worse, because some physician thought, what if they have an allergy? I've heard of a case where someone died because the hospital withheld antivenom thinking the person may be allergic. Well, what's worse than death?
Right. And I've heard, some people say, oh, well, they gave him just a tiny bit, see how he would react, and then they would give more.
Yeah, and that's just dumb. Either do it right or don't do anything.
Right. Yeah. Having one foot in the canoe. So.
Yeah.
But yeah, Jason had a reply. He said, I had a CPK count of over 120K when I had rhabdo, non-snake related. And he goes, I keep a few hots and want to be prepared if I'm predisposed. And he also only has one kidney, so.
Okay. Well, he has one kidney, so obviously we'd be more worried about rhabdo. But having rhabdo from something else doesn't mean you'll have it from a snake bite. I was septic from pneumococcal pneumonia. It doesn't mean that, every time someone sneezes in front of me, I have to get checked out in the hospital.
Right.
So, sorry, Jason. I don't want to make too much fun of you.
He's been around a while, so I don't think he's I don't think he's heading anywhere.
But hi to my friends in Alabama while I'm on the line.
Oh yeah. So what is has everything you've done been domestic, or have you done any research overseas or South America?
So I've done research on non-native snakes. In fact, I just published an article on Central and South American coral snakes in current tropical medicine reports. Actually, I don't remember the name of the journal. But yeah, just literally in the last 2 weeks, I published something about Central and South American coral snakes. I'm fascinated by. Mm-hmm. And of course, I love the white-lipped tree viper, native to Southeast Asia, Thailand. But I haven't traveled anywhere. I've done all my work from Houston or Arizona, with occasional work on a plane elsewhere. But no, I haven't traveled anywhere. But I am fascinated with the exotic snakes, and we're working on some publications related to the squam as well. So I've been lucky enough to treat maybe about 30 or so exotic bites. So I'm familiar with exotic snakes. I just haven't gone there in person. Not like my colleagues like Nick and Jordan,
Right, and
who actually go to Africa. So yeah, I do everything from the comfort of my own home. Some people are great in the wild. My idea of roughing it is like when a hotel has a limited room service menu. So
that's why you got to put it in your rider, So, I guess let's see, where do you see the most development happening? As far as the understanding. Like what's kind of the forefront of things. Of course, there's these conferences, but if like what's making the progress?
I think we're addressing the issue of snakebite on several fronts simultaneously. Mm-hmm. Here in the States, I think just educating people about the indications for antivenom is a huge thing. I think educating people on the lack of utility of antibiotics in surgery and antihistamines is a huge thing. I think worldwide, telling people how to avoid getting bitten in the first place. We know that it's a neglected tropical disease. We know that snake bites are a disease of poverty. People get bitten occupationally because they're out where the snakes are and they're not taking appropriate care. So there's that, educating people how to avoid snake bites in the first place. And then, especially in these poorer communities, emphasizing the role of modern medicine over more traditional cures that don't actually help the patient. They just delay appropriate treatments.
Right, witch doctors and different things like that. And that was one of the things that, I never thought to ask that question until I went to the Venom conference last year. Is I started learning about how, I guess it's the equivalent of, I've got some rosemary and, patchouli essential oils. Let me just rub them on, and, and it's like you say, sometimes, especially here in North America, most of the time they'll be okay. But over there, they're dealing with something, or identification of the snake, not
right.
being bit by a non-venomous. It's, the witch doctor works because this person, they turned out fine. So
exactly.
So yeah, I love the education aspects, the electricity. I think just for fun, I'll probably go buy one of those anti-venom tasers or to neutralize the venom, and then go around a herp show shocking people or something like that. So
I mean, I'm torn about the whole electrical therapy because it's certainly fun in a Tarantino sort of way to like hook your friends up to a car battery or a taser or whatever. But people need to understand it's not at all beneficial for an envenomation.
Right.
It will halt the progression of venom effects if you in fact kill the person. But beyond that, it's not going to help. All it'll do is cause a burn, to complement the venom effects they already have.
Right. So, also as we go along, I've got people saying, stay crofabulous, and witch hazel and
Yes.
peppermint, lavender for a Keystradon. But y'all are more than welcome to chime in, ask questions. We've got 11 people concurrently, 12 people concurrently right now. Um,
Okay.
but so I'm sure some people are sticking around, and then we got some people dipping and going. So we try and be interesting. As far as papers, you've done a lot of papers, and I, from my understanding, those take a while to publish. So what's been your process for writing and going um, and tackling that end of things?
Well, I'm involved with two big groups. The North American Snakebite Registry is part of the Toxicology Investigators Consortium,
Mm-hmm.
administered by the American College of Medical Toxicology. So I've been involved with a few papers as someone who contributes a lot to that registry. Uh, we've published the epidemiology article by Michelle Rua et al. We published the cottonmouth paper by Krista Demansky et al. I'm working on a coral snake paper right now, and then that group has published some other things that I wasn't an author for. And then I was fortunate enough to be in the copperhead study, and we published the big randomized clinical trial showing that crofab was beneficial even for mild copperhead bites. And I think we published 5 other papers based on that study. And I'm working on the pediatric, technically adolescent, sub-analysis of that, and I'm hoping to submit that for publication literally in the next few days. And then I've published a few things on my own. I'm doing some poison center data research right now on coral snakes, and some get published quickly, some take a long time. It depends on the type of paper, whether it's original research versus a case report. The letter to the editor was accepted for publication like a week after I submitted it, and was published a few weeks after that.
Mm-hmm.
The case report of my friend/patient who was bitten by a white-lipped tree viper was accepted pretty quickly and was published shortly thereafter. So the big thing is time. It's always time. I'm trying to finish 1 or 2 more papers this month, understanding that the month is over in 2 days.
Mm-hmm.
And then there's 2 or 3 things I want to work on in February. Like right now, I have a list of maybe 20 papers that I could be working on. Some of them will probably never get done. And there's a few projects that I abandoned. Like years ago, I was collecting data on the synthetic cannabinoids,
Mm-hmm.
the kush that still is affecting Southeast Texas. And I had a ton of data, and ultimately I'm like, you know what? I don't have time for this. This isn't the focus of my research. This isn't my big clinical interest. I want to focus on envenomations. But I have some scorpion stuff I want to write up. I have some spider. Actually, I think there's one spider thing I have to work on. I literally have a list of projects I need to get to eventually.
Right. So a lot of research papers. You ever going to write like a common book? Just for the average, I guess, reptile enthusiast.
I've thought about it. I don't know if it's worth the time financially.
Mm-hmm.
Maybe when I retire, I will. I don't know. I have all these great stories, people, how they got bitten, and I don't know. I've thought about writing a book specifically for envenomations, and a bigger one just on tox in general, but I don't know. We'll see.
Right. So what are slow days in the office? Because I imagine people aren't getting bit constantly. So is it just kind of like, I guess, when you were more on the on the floor, or I guess on the frontline side of things, when people aren't getting bit, what's the day like?
So, I mean, every day I have, I do a lot of expert work. So I have cases to review and work to do on that. Every day I'm doing something for the conferences, or almost every day. I'm always giving lectures. And even though I lecture all the time on snake bites, they're to different audiences, so I have to tailor the lectures. And one of my pet peeves is when people don't update their slides. I remember going to a lecture in 2007, and it was a phenomenal lecture given by someone who knows a ton about envenomations.
Mm-hmm.
And I was so impressed. And then I attended a lecture by the same speaker in 2018, and it was the same talk. It wasn't updated in 11 years. And that is one of the 2 cardinal sins of PowerPoint presentations. The other one, of course, is when you have tons of text and, no pictures on a slide, and then you read off the slide. I think that's just abhorrent. But
See, as a graphic designer, my sins are if they use Papyrus or Curls MT, you know, so different things like that. But it almost goes back to the for-profit thing. It's like if the same talk is still making him money, why should he change it? But it's like
because information changes. It's not the same information anymore.
Right.
I mean, hell, in 2007, we didn't even know that you could use CrowFab for copperheads. Now we know you ought to.
Mm-hmm.
There were so many things that we learned in the interim. So I literally update my lectures every time I give them, even if it's just a tweak here and there. I mean, I'm giving 3 lectures in the next 5 days, and I just updated them in the last 2 weeks. So I'm always doing that stuff. Then, of course, as much as I love envenomations and tox patients, I also have a life. We have our foster animals and our regular animals that are ours. There was a time a few weeks ago where we had 12 cats in the house.
I've been waiting for a cat to come and screen. So
well, there's no cats in this office. I'm in my home office right now, and the cats are nowhere near here. There are 2 dogs just adjacent. They've been very well behaved. I did put a sign on the front door saying, "Do not ring the bell." From this hour to this hour, so that the dogs wouldn't go in a tizzy. But yeah, no, most of the animals are sleeping right now.
Is that a medical term, a tizzy?
It can be.
Sorry, I know your friends are also here, so I wanted to make sure.
I would have no qualms putting it in a chart.
Yeah.
So therefore, it must be a medical term. So yeah, and then what else do I do? Got to take care of myself. But otherwise, professionally, it's the lectures and the consulting, trying to help other people. So I provide indirect care by helping other hospitals and EMS providers be better at treating tox patients. So I always have a million things to do.
On the people who send patients home and not, provide antivenom, have you ever just gotten frustrated and sent an email?
Absolutely. Absolutely.
So
it's generally poorly received because people don't like to be told they're doing something wrong. And I sometimes lack tact at the expense of, in an effort to be direct, I lack tact. But every once in a while, people do learn. I have contacted people like, look, and I've even offered to provide education. We had a great win. There was a hospital in South Texas back in July that so they wanted to horribly mismanage a bite. Fortunately, it was a teenager whose mother was really familiar with snakebite protocols because of her involvement as a member of National Snakebite Support. So the kid ended up getting appropriate care, but it was kind of despite what the hospital wanted to do, not because of what they wanted to do. A few of the people there acknowledged that they didn't know anything about bites, so they knew what they didn't know. Others didn't understand that, but nonetheless, she advocated for her child. He got appropriate treatment. He did fine. But then the next day, there was a senior physician at the hospital who was livid about everything that happened and had said that, had he been involved with the decision making, none of that would have happened. And he was just saying a lot of incorrect things.
Right.
And it was scary because, his was a respected voice in that hospital. We ended up contacting the leadership at that hospital. I went down there. We talked to them about everything he said, showed them the literature that contradicted what he said, and I ended up getting an opportunity to give a lecture down there, and we had people from the emergency department and the ICU attend, and I taught them. It was actually really cool. So it was a surgeon who was just saying everything wrong about snake bites, and it was a pediatric patient. So I actually brought a copy of a pediatric surgery textbook with me, and we documented everything he said, and I showed him in the textbook on snake bites in the pediatric surgery book that contradicted what he said. And then I pointed out that I knew the chapter would contradict what he said, and I showed him it's because I wrote the chapter. So I wrote the chapter in the book that he considers the Bible.
Do you know who I am? So
that was kind of it. I brought a copy of about 15 articles I co-authored or authored, and
sign
I brought
it,
the
leave it
textbook
for
that
him.
I authored. I'm like, well, you're saying that your college of surgeon says not to do this, but your Bible says to do this, and I knew it would because I wrote your Bible.
Ooh, So, yeah, no, that's great because I know so many, doctors, like it must be like you go up to them, it's like, yeah, you went to school for 10 years, but that's 10 years of wrong. But it's,
Well, the problem is half of what you learn in medical school turns out to be incorrect, and you don't know which half it's going to be at first. So,
oh, fun. Yeah. So I guess that's why you're writing 20 papers right now.
well, hopefully, eventually, get
But
them all done.
but on the side of parents advocating for their kids, I've always heard the stigma of doctors get frustrated. It's like, oh, I went to medical school, and it's like you're like, well, here's an example of where they should. So.
Well, here's the thing: you can advocate for your child or for yourself while still being respectful and professional.
Mm-hmm.
I recently had a patient's mother who was unreasonable. It was easy to fix, and she left happy. But what she was doing is unreasonable. What we encourage people to do is ask questions like, "Hey, what are your indications for antivenom?" And if they say, "Well, we don't give antivenom for coppers," she says, "Well, what about all these studies that suggest?" And of course, we try to arm them with the literature.
Mm-hmm.
What patients need to know is they can always advocate for themselves by requesting a transfer if necessary, or asking that they consult an expert. Patients have to know their options. They have to know that they're not at the mercy of a doctor. He or she can't just do what the physician wants to do. But while we're at it, that's also a good point. So I think it should be perfectly legal to own venomous exotic snakes if you have permits. But I think that with that right comes the responsibility. I think you need to either have your own antivenom or belong to a community antivenom bank. Have a way of getting the appropriate treatment if necessary. Don't rely on the kindness of your local zoo, etc., because some zoos won't have what you need and some zoos won't give you what you need. There are some zoos that will not give out their exotic antivenom. They save it only for their staff. And while other ones are more generous, Houston Zoo has been terrific, it's not their responsibility. They need it for their own people.
Right.
So I think you should be obligated to have a mechanism of having your own antivenom. Some keepers mistakenly believe that if they come to the hospital with a bite and they bring the answer to say, hey, this is what you use, that they can force the doctor to use it. No, they can't. Ultimately, a doctor is operating under his or her license. It is the doctor's decision. Now, they can be sued if they don't treat the patient correctly and there's a bad outcome. But you can't force a doctor to do anything or to do nothing. So you can suggest it, and if the doctor's not familiar, he or she can contact an expert. One of the reasons I want all the exotic bites to come to me when I have a snake bite service up and running is because I know the indications for the exotic antivenom. I know which exotic antivenom to use, but most doctors are not going to have that information.
Mm-hmm.
They're not going to have that experience. They think it's so keepers will think, oh, well, I can just tell them to give this cobra antivenom. Well, no, you can't force them to do anything. You can try to educate as quickly. And of course, I think it makes more sense to be proactive before you get bitten. Establish a contact at your local emergency department, explain what you have, explain what resources you have in case, God forbid, there's a bite.
Mm-hmm.
The problem is, again, this is such a niche little thing. This is such a small percentage of all things. That's why a lot of doctors never learn about it. Heart attacks, stroke, cancer, pneumonia. These are things you see on a daily basis.
Mm-hmm.
Most physicians will not treat a bite in their careers, or maybe they'll treat one bite. I'll see more in a busy month than most of them will ever see if they practice for 50 years. It's just such an obscure little thing.
Right. So, and so it's also getting that motivation to go and, to these talks, read these papers, different things like that, if it's such a niche thing.
So I think we're running down on time. I may have to go retrieve a child from the bus stop.
Oh, fun times. Well, I'll take this opportunity real quick to throw out last opportunity for questions for our chat. Right now, they say, I'm not going to med school. Instead, I get my reliable medical advice from YouTube podcasts and Facebook. But yeah, real quick, if you guys want to ask any last questions, we'll have Dr. Greene answer them before he has to take off to a bus stop. And I think the reception's been pretty good. I had the other one down, so we've had... Oh, I'm not sure what that delay is.
I'm not getting any hate emails or hate texts.
No, no one yet. I think those are pretty Eric far away. Ha. So, um, maybe I shouldn't say that. But uh,
I didn't hear anything.
I heard nothing. This mic has some static. But yeah, let's see. On the last couple questions on my end, as far as these papers you've been referencing, or more research, where do people need to go to find and access things like this?
So in National Snakebite Support, we have a file repository with pretty much every article I've mentioned. Anytime I publish one or anytime one of my colleagues publishes one, we make sure we upload it so they can access there. And if people want them, they can just email me too, and I can give them a copy. I was actually transferring my file folder for snake-related articles today. I think I have 450 something articles in that folder. So
Nice.
I have all of them.
And Jason Whately promises to borrow or to get a kitten from you, whichever one's up for adoption.
No one's up for adoption right now, so we can't have any of them. But kitten season will start in the spring. The problem is actually we work with Houston Pets Alive, and in general, the cats have to remain in Texas. So, but he's welcome to move to Texas and adopt one of our fosters.
You know what they say, Texas is the best country in the world, but all right, well, I guess we will go ahead and wrap things up. Thanks to everyone who came through. Definitely join the I forgot the name of the page. Wow.
National Snakebite Support.
National is a first word. So National Snakebite Support page. I'm sure most people who are watching live are likely already a part of that. The Houston Venom Conference. And
yes, sign up today and buy a shirt. We're out of the big sizes, but we have enough for you little people. So we have small through 2XL. We are sold out of 3XL and 4XL.
Awesome. So we will, and the dates for the Venom Conference again, May.
So Houston is Saturday, May 16, and the first annual New Orleans conference is scheduled for Saturday, November 7. And I'll be posting more about that in the upcoming months.
Sweet. And New Orleans. Where's the after party in New Orleans?
The after party after the whole thing?
Or
I don't know yet.
Or like there's that, and then I know there's a zoo trip for Houston.
Yeah, the Audubon Zoo is where we're having the reception in New Orleans.
Oh, okay, yeah. Things are connecting in my head now. But awesome. Well, Dr. Greene, thanks so much for coming in, talking, and I'm sure I'll think of 100 questions to post to the page later that I should have been thinking of now, but
No, thanks for doing this. This is my pleasure.
Awesome. Well, we will talk to you later on.
All right.
All right. And okay, there we go. So I was one of those people who did think Benadryl just because I was told it and I regurgitated it. So hearing that perspective on a medical level, that's pretty wild. But again, thank you guys so much for tuning in, and we will see you guys next time.